Welcome to the first speaker series session of the new semester. I will go ahead and introduce our speaker. So today we have the pleasure of hearing from Dr. Susan Hickman, who is a geropsychologist, professor in the Indiana University School of Nursing and IU School of Medicine, Cornelius and Yvonne Pettinga Chair in Aging Research and Director of the IU Center for Aging Research at the Regenstrief Institute, Inc., as well as a co-director of the Research in Palliative and End-of-Life Communication and Training Center. She is serving as the interim president and CEO of Regenstrief Institute. Dr. Hickman's been educating and conducting research on advanced care planning and end-of-life decision-making with a focus on the nursing facility since 1998. She's currently the co-principal investigator on a National Institute on Aging pragmatic randomized clinical trial to evaluate an advanced care planning program for caregivers of nursing home residents with Alzheimer's disease and related dementias, as well as a bioethics supplement to explore family experiences with these conversations. Dr. Hickman is also a co-investigator on 2 NIA-funded trials that include advanced care planning interventions. She recently completed a grant funded by the National Institutes of Nursing Research to evaluate the quality of advanced care planning decisions in the nursing facility setting by assessing concordance between current preferences and existing documentation. As a co-founder and leader in the Indiana Patient Preferences Coalition Community Stakeholder Group, she has championed the nearly unanimous passage of 4 end-of-life decision-making statutes in the Indiana General Assembly over the past decade. Today, she'll be presenting her talk, Decisions That Matter, Translating Research into Policy and Practice. We're so glad to have you, Dr. Hickman, and I will give you the floor now.
Thank you so much, Al. I really appreciate that introduction and the invitation to present. I'm going to do a brief shout out to Liza Cohen, who I'm so delighted to see, and had the pleasure of working with her for many years when she was with the IU Center for Aging Research. So great to see you. Today, I'm going to provide an overview of my research and include in that some ideas about work in the interdisciplinary space and ways in which you can make use of your training and education in ways that you maybe didn't anticipate. I certainly know I did not anticipate my career going in the directions that it's gone in when I completed my, my doctorate many, many years ago. All right, so I'll start by saying that my work focuses on communication and decision-making near the end of life. And I spend the bulk of my time really focused on building the evidence base in this space. And so today I'm going to talk about that work and then how it bridges into 2 areas, both policy and then into practice. The work is really multidimensional. As you can see, it's implied by the bidirectional arrows. The research feeds practice, practice feeds policy. It is really multidirectional in the ways in which my work grows and builds off of the different things that I'm doing, depending on what I'm focused on at the time. I will say a thread that underlies all of the work that I do is it's all interdisciplinary, and that's a really critical part of my work. In part, the areas that I focus on are largely interdisciplinary fields. And so it really logically is the case that that is reflected in the other kinds of work and implementation work that I do. Okay, so this is not a great picture of the University of Kansas, but I'm a KU Jayhawk. I went to graduate school at the University of Kansas in their clinical psychology program. A very long time ago. And at that time, I actually went straight out of my undergraduate program, and I majored in psychology as an undergrad and knew I wanted to do clinical psychology. I saw no reason to take any time. I might make a different decision now, but the work that I pursued when I was a graduate student focused on issues related to sexual assault and rape and acquaintance rape. And I have on the screen here my dissertation, a manuscript based on my dissertation, which is many, many years old and is now my most cited article, probably just because it's so old. But the reason I share that is in part, I really did enter into my graduate program a little bit unclear about what I wanted to do. This was an area that was of great interest to me. I had a fabulous advisor. But one of the things I did as a student is I took advantage of different opportunities to explore areas that were of interest to me. And one area that had long been an interest of mine was working with older adults. And so I did do a practicum at our local VA. It was offered by a graduate of our program, and she exposed me to neuropsych testing and working with older adults and patients. And I found that to be incredibly exciting and interesting. And when it came time for me to pursue to select a internship placement, I really focused in on programs that had a strong gero component because I knew I was interested and I wanted to explore it more. So I ended up building my whole career, as you will hear, around geriatrics, but I didn't start out with that as my focus of my research. And that was really something that came together over time. I did do my internship at the Portland VA Medical Center. They had a really great program with a strong gero rotation, although it wasn't exclusively gero. And it was a really transformative experience for me. I absolutely fell in love with the population. I absolutely fell in love with the work and the complexity and the interdisciplinary nature of that work. I did a lot of work in evaluations and worked with interdisciplinary teams around supporting older adults and their caregivers. Again, just very exciting work for me. That led me to do a postdoc in gero at the VA. And after I graduated, instead of moving into a clinical role, which frankly I'd always assumed I would do, I took a position with Oregon Health and Science University. The reasons for that were really related to my clinical experience. So, as a clinical psychologist, I worked with several patients as a postdoc specifically, I worked with several patients who were near the end of life. And I was really struck with how confusing it was and how problematic our healthcare system is. That creates these barriers and ambiguity about what's happening. It's really difficult to communicate between settings. And I, at the time, put a lot of energy into supporting a couple of patients in particular. And it became very apparent to me, despite the fact that there was effectively a full-time PhD focused on trying to help ensure that their care that there was care continuity and that their needs were met, that there were huge gaps in the system that even one well-intentioned person could not fix. And it became apparent to me that, we really had a system that was not set up well to take care of these patients near the end of life and take into consideration their significant needs, which are different than a younger population. To give you some sense of the experience, I encourage you, I've used this analogy to think about it like you're driving down a road at night and, all you can see is what's right in front of you on the road. You can't see signs up ahead. There's nothing lit up. You don't know when there are turns that you need to take. And in fact, you might not realize that you've passed the turn you might have wanted until you're many miles down the road. And this is often the experience of seriously ill patients and their families. There's really no clarity about where they're going, about why they're headed there, and they can't really see where there are opportunities to sort of exit what you might consider to be this highway of intervention and treatment. And for some people, that's a great road for them to be on, and other people, find themselves very far down the road and then wonder why they're doing it. So this led me this is the experience of any adults with life-limiting conditions. It really led me to think about what are some systems issues and how can we help these people. And really what they need is a map. And a map that is, coordinated. And I love the analogy of a map because it really speaks to this issue of a systems level, right? Because a map is a map of a highway system that shows you all the different branches and opportunities and directions and provides you guidance about where you're going, about where you are and where you're going. And I first encountered this this concept called the POST, or physician. It says POLS because that's the national model. I'm going to call it POST just for, it's the Indiana version, Physician Orders for Scope of Treatment. And I first encountered this at a state gerontological association meeting. And it was this idea that, really part of the challenge in providing end-of-life care that is consistent with people's goals and values is that nobody is really talking with them about their goals and values, and that we need some more structured approach to both eliciting those preferences and documenting. And that's where the POST comes in. POST is a medical order form that is used to document preferences as actionable orders. And these are then signed by a physician and the patient or their surrogate, and are used to guide care, particularly in emergency situations where that individual lacks the ability to make their own decisions. And I love this because it has common language. It's standardized like a map is. To build on that analogy, it tells you where you are and where you might go, and what So if you're currently in you're seriously ill, but you're continuing to receive chemotherapy, for example, it shows you might make a selection to be full intervention, but it also gives you this idea like, well, at some point I could opt to be limited additional interventions or even comfort measures, right? These are possible directions you could take in the future. I think, the reason PULSE was developed is because so often people did express preferences, had conversations, and then that information got lost during transfers. And it's particularly challenging for emergency medical responders because they are required to provide all available interventions. And that really works for the majority of people that they take care of. They arrive at a scene. That's what you want. If you're in a car accident, you want the EMTs there as quickly as possible to give you all available interventions. But if you're a frail 90-year-old nursing home resident with advanced dementia, that might not be the best course of action for you. And unfortunately, absent any orders from a physician, EMTs still need to provide everything to you. And so this is where PULSE really becomes a valuable tool, because it helps ensure that those orders are documented, and then the way they are codified in our state statutes, it allows or authorizes, actually requires emergency medical responders to honor them. So they actually have what they need to be able to honor that person's preferences for less aggressive interventions, including potentially withholding cardiopulmonary resuscitation. The other piece that I find so appealing about PULSE is that it is really a communication tool that communicates preferences and goals across a variety of stakeholders and important participants in the care system. So there's in green, the patient and the family, and obviously they're the most important, and there's also the threat of continuity across all these settings, but it is valid in the long-term care setting. It is valid in the community. Emergency medical responders can honor it. And then in the hospital, it's valid in the emergency department until orders are written at the time of admission, and it should be used to guide those orders. So, it's really a valuable tool. It is now the standard of care throughout the country, and much of my work that I'll describe today is focused on this tool, but it wasn't always the case. And in fact, when I finished my geropsychology fellowship, I think I indicated I took a position at OHSU. Again, I always thought that I would be in a clinical role, and in fact had a couple of offers on the table when I made that decision to instead go this route of a more academic role. And what appealed to me was the opportunity to work on a grant that was funded by the Robert Wood Johnson Foundation to identify systems approaches to improving care of the dying. And I spent several years in this role. My first job was to drive all around the state of Oregon to meet with healthcare providers in all different settings to learn about their experiences taking care of seriously ill people. And we compiled that in what we called the Oregon Report Card to provide us some guidance about where are the areas we need to focus our efforts in system change. How are we doing? Where do we need to go? I very quickly, as in this role, which was we called it a project director, called various things, or it might be a research manager or program director, depending on your setting. I quickly became involved in a variety of studies and even secured grant funding to do some work from the Greenwell Foundation of New York. We did 2 studies with that funding. The first was a study of emergency medical responders' experiences with this tool. And obviously, that was really important because, as I shared in the previous slide, they're a critical part of the system and often a place where we see preferences get lost during those transfers. We talked to almost 700 emergency medical responders about their experiences with PULST and had them complete surveys. We didn't talk to them, we had them complete surveys. This is so long ago, it was literally like stuffing envelopes and mailing them. We heard back that 75% of them thought that the PULST actually provided clear instructions for them. And when it was present at the scene, it changed outcomes for those patients 45% of the time. So clearly an impactful tool. We also did a study based in nursing homes, which is a setting that I really care passionately about. We did a review at 8 different buildings and found a couple of interesting things. One of them is, there's sort of this assumption historically that if you know whether or not someone wants resuscitation attempted, which is called their code status, that you understand their broader preferences for care. We found that was not at all true. Code status orders were not predictive of other orders, meaning just because someone wanted resuscitation withheld did not mean they wanted a focus exclusively on comfort. They might want other kinds of interventions. This was sort of new in the field. Now it's almost 20 years ago, but was an important contribution and also highlighted how the tool was useful in providing more patient-centered, individualized care plans. I was hired as a faculty member at the Oregon Health and Science University School of Nursing in 2003 and secured funding from the National Institute of Nursing Research to do a multi-site study of this tool in states that were relatively early adopters of use: Oregon, Wisconsin, and West Virginia. Those are pictures of my teams in those 3 states, including myself a very long time ago. It was a really kind of daunting task to, I did my dissertation with undergraduate students who were in intro psych. So it was a kind of a jump to be coordinating these multi-site teams, but it was a really great experience. And we had a lot of really great findings out of the project. We ended up with a random stratified sample of nursing facilities in all 3 states. In every state, we did 15 facilities where they used the tool, 15 where they didn't. We looked at 1,800 medical records that were randomly selected to understand how PULST impacted treatment. There was a lot of work to ensure fidelity to the methods, and I was really fortunate at the time. I was also had been sort of serendipitously involved in a study of bright light therapy to treat persons with dementia in a totally different study with a team from the University of North Carolina who were really great role models for how to run such a large, complex study. Our findings were, really significant in a couple of ways. First, we found that residents who have PULST had much better documentation about their preferences. If the facility didn't use PULST, they generally knew very little to nothing about what the person's preferences were, which is a little bit alarming, given that nursing facilities take care of some of our sickest and most frail population within the healthcare system. We also found that PULST was significantly associated with lower use of life-sustaining interventions, specifically hospitalization as an intervention tool. I'm going to just talk a little bit more about that. So in the PULST form, there are 3 levels of orders around medical interventions. There's comfort measures, where the goal is to maximize comfort. There are limited additional interventions, where the treatment goal is to stabilize the medical condition. And then full intervention, which is standard of care. And so we looked specifically at the kinds of treatments that were provided based on what the order was. And we found that for residents with comfort care, there about 13% had documentation of life-sustaining treatment use in a 2-month period. That increased a little bit for those with limited additional interventions, and pulseful treatment, 23% had some sort of evidence of a life-sustaining intervention. These were significantly different from comfort care. Then we also looked at those who didn't have pulse at all, they didn't use the tool, and that was also significantly different from comfort care, but similar to pulseful treatment, which is also enormously reassuring. Sorry, I'm a little bit in the weeds here, but the takeaway is that pulsed orders are consistent with the medical treatments people provide. That's the big important takeaway, and really significant because some of the other approaches that have been used historically have not been effective, including living wills, which some of you may be familiar with, are really much more philosophical statements about preferences that by and large make no difference in the healthcare setting for a long list of reasons. So this was an important finding. One of the things that we really struggled with was also this consistency issue to how do you determine if, when you're looking at a treatment in the chart, if it was consistent with the order. We spent a lot of time thinking through how you would calculate and describe that. Several years later, I wrote a paper with my colleagues at the IU Center for Aging Research, Kathleen Unroe and Lexi Torkey, in which we described some of the complexities in measuring this really important indicator. That was really an interesting exercise because people were really excited about this consistency, or concordance is another word they use to describe it, but it's really hard to measure. So having this be sort of the first goal you might have for a palliative care program, for example, is really challenging because they're going to struggle to measure and document that as an outcome. So I want to remind you, I shared with you this idea of a journey of driving down a dark road, and I describe pulse as a map, and it certainly helps you to know where you're going and where you've been to an extent. But another thing that's really critical in this process is that in order for your map to be helpful, you need signs and markers. You need a system of signs and markers, right? So it's all well and good to have that tool in one nursing home, but everyone needs to understand that. And also keep in mind that people live in all parts of states, including around the border between other states. So we started to get requests from other parts of the country to learn more about pulse. I ended up becoming involved and actually leading a project with colleagues at the American Bar Association and the West Virginia Center for End-of-Life Care, looking at legal barriers to use of pulse. Again, it's not what I went to graduate school in clinical psychology to do, but it was an interest of mine, and it was really, again, gets at that issue of system, and it really pulled me into issues related to policy because there were really significant barriers in some states related to their state laws. And you can't just say everyone's going to use this everywhere, because each state had different laws that constrained or frankly made it impossible to use this pulse tool in their states. And so we did essentially a survey of that and published that and started doing more consultation around that. Ironically, one of the states that came up as having significant barriers was Indiana. And at the time, I was still living in Oregon, and just shortly after this article came out, we made the decision to relocate to Indiana, and I realized, like, oh dear, like I'm moving to a state where the thing that I study does not exist, and there are significant legal barriers. So it was a little bit of a stressful time trying to figure out what I was going to do next. Well, it turned out that what happened is I got pretty quickly pulled into trying to create policy change within the state of Indiana. So when I relocated, there was no pulse program in Indiana. And in fact, there were those significant legal barriers I referenced, but I did this thing that we do in academics where I kind of did this introduction to my work as part of my introduction to the broader Indianapolis community. And I gave a public lecture at the Methodist Hospital, which is part of IU Health. I had a lot of people approach me and say, we want to do this here. And I was thinking, no, we can't do this here. It's like almost impossible. But a group of us got together and crafted a plan. We formed a group called the Indiana Patient Preferences Coalition, and in pretty short order, we drafted legislation and introduced it in 2012. We had to go back to fix a few things, and in 2013 it passed nearly unanimously. And so in that, 4-year period from when I moved to 2013, we were able to move this legislation forward and develop a program in the state of Indiana, overcoming all of those obstacles that I had identified with my colleagues in the publication with the Bar Association. Not long after, I did a study in which we looked at use of POST a few years later as part of another NIH-funded study, and we found that POST use had actually taken off quite quickly. In fact, 65% of nursing homes were using POST with residents after admission, which was pretty remarkable in just a 3-year period. We were really delighted. And I will say that first POST legislation was the first in a series of policy activities that I've undergone and been involved with and led. And I now have a decade of leadership experience related to policy work under my belt, which again, not something I thought. It was really about like when, this idea when a door opens, if you walk through it and take advantage of that opportunity. Because of my work on the POST Act, I was invited to chair the Indiana Palliative Care and Quality of Life Advisory Council, which was a legislatively convened council that looked at our palliative care landscape and identified policy priorities. In 2018, we had two additional pieces of legislation that passed to make some modifications to our original POST legislation and make some other important updates to our proxy hierarchy. And then in 2021, we did a really significant overhaul of our advanced directives. Just yesterday, literally yesterday, I testified about this final item on here, the out-of-hospital DNR. And I'm not going to dig into the details and belabor it, but we did work with the legislator to sponsor House Bill 1458 to address a problem that had been identified and with the out-of-hospital DNR order form. And our hope passed out of committee unanimously, 13-0. We're hopeful it will be successful. But again, this is sort of a part of I didn't train for this in my graduate program, but it was an opportunity. And I will tell you, it's actually pretty exciting because we've been able to make changes that really make a difference in how practice is delivered and how clinicians practice. And this work is all of this work has been done with interdisciplinary colleagues. And I routinely work with palliative care physicians specifically and geriatricians, as well as attorneys, and then advocacy groups, as well as industry organizations in the state. It's been really productive collaborations that have allowed us to do this work and to pass basically everything we've done. We've passed with only one opposing vote in 4 bills. So we feel pretty good about that track record, but it's because we have worked so closely together and draw upon the strengths of that group. That work's been recognized, which has been lovely. The Indiana Patient Preferences Coalition, again, it's a large interdisciplinary group, and we have been grateful for the support that we've received. We also, I will say, once we passed that law in 2013 to develop POST, I realized that our work had just begun. Actually, I was kind of like, phew, that was hard. And then we realized we needed to create educational materials and a website and blah, blah, blah. So I got funding from Walther Cancer Foundation to create educational videos that are used in the clinical setting and are available online. These are really important in supporting practice and supporting implementation. And it's been really a tremendous experience to be able to, and a real challenge to take, like I now live and breathe academics, right, to then create content that's more publicly facing and is really lower health literacy. This video, for example, in order to ensure that it was easily digestible and understood, I repeatedly ran the script through a check to assess the reading level to ensure that it was below the 8th grade reading level. which was quite a feat with some of the complicated terms, but really important to ensure that we're accessible and able to reach a diverse population. Additionally, I've been involved in national work. I'm not going to spend a ton of time on that, but in 2004, I helped co-found a group called the National Pulse Paradigm. I continue to be involved. I, in fact, have a meeting with this group this afternoon. Additionally, had the honor of being invited to provide testimony as part of a report by the Institute of Medicine called Dying in America. They wanted to incorporate information about pulse, which they did. I cited it as sort of a key model for improving care based in part on the work that I'd done previously. And so this has been a large part of how I spend my time, is talking with other states and researchers around the country and clinicians about challenges they run into. That continues to be an ongoing work. I've also shared our story, with other national groups, including the National Institute of Nursing Research Advisory Council. Those are all the people that make funding decisions. So it's always nice to get in front of them. I was invited with 2 colleagues to talk about kind of broader issues of research and practice translation. So I'm going to go back to my map analogy. So, you want to make sure that, when you have a map in a system that includes, lights and signs and markers, that you can figure out where you're at, where you're going, right? And as well as alternative routes. And so some of the work that, once you do this, you want to make sure people are actually using it. And so we have been tracking that nationally. So, when I think about my experience with Pulse, I think not just about the impact in Indiana, although I just described to you some of the legislative work, but also how it drives change across the country. So I'll just share briefly, this was a map of states using Pulse in 2010 when I first was a new Hoosier and was learning about the state and getting to know people. And there were just a handful of these states that are in the dark pink that were endorsed, meaning they met all of the national program requirements and that we had developed. Many states were developing, though only about half, and Indiana was white. There was no program, there was nothing. By 2018, the map had changed markedly. This has really spread as the standard of care across the country. And I've been really fortunate to be a part of this work, although I will tell you there are hundreds of volunteers around the country like me who have committed time, energy, resources to making this possible and making this tool something that's more widespread in the standard of care. So I'm also been fortunate to be involved in a couple of different projects where we have worked to implement Pulse and support that implementation in Indiana. So this is a picture of a team, the Optimistic team. This is a project that Liza worked on. Although Liza, you must have not been with the team at the time the photo was taken. It was an 8-year project. So there were a couple changes over the years, and we were lucky to add Liza. But this was a really neat and unusual opportunity to do a really practice-focused project. We implemented a multi-component model of care in nursing facilities with the goal of reducing potentially avoidable hospitalizations. Now, you've heard me talk about hospitalizations in nursing home residents about 4 times now, right? So this is a big deal. And it's such a big deal that the Centers for Medicare and Medicaid Services invested over $100 million in trying to find strategies to reduce potentially avoidable hospitalizations because of the harmful consequences of those. We included Pulse as one of our tools that we used and did implementation. It was a really neat experience, worked very closely with the nurses who were part of our team. That's a large number of the folks you see in this photo are nurses and nurse practitioners. And then we did trainings that I led to train people in facilitating advanced care planning conversations with a couple hundred nursing home staff around the state. Again, this is we talk about translating research into practice. This is a huge part of that work that I've been fortunate to be a part of, to be able to share this new tool and give people really evidence-based strategies for working with it. Additionally, I've done more work to, I feel some ongoing obligation to continue to build the science in this area. So I did have a grant in 2015 in which we looked at an issue that had been long in the back of my head, this issue of whether or not the orders that are recorded and on file in the nursing home match that person's current preferences. Because it's possible in that time period from when the orders were written to when they are acted upon that there's a change in preferences or values. We did indeed find some discordance between preferences and values. One of the things that was really interesting out of this is we found several important areas for future work. One of them is that people have a very poor understanding of some of the very basic decisions that they're making. They don't have the knowledge necessarily they need to make some of the decisions that are recorded on POLST. One of the questions we asked people is to tell us how many seriously ill people they believe survive CPR. And the most common response was about half. The answer is closer to about 5%. So not very many would be the better answer in this case, right? So people way overestimate the likelihood of a benefit from cardiopulmonary resuscitation and often opt for that more aggressive route, not understanding that it comes with some pretty significant risks for this population who are far less likely to benefit from CPR. Actually, in the nursing home, this is more accurate. In the nursing home, it's actually less than 3% of residents survive CPR. We also were interested, as I said, in this discordance between current preferences and documentation. We did find discordance in residents with POLST forms, but we also found even greater discordance when POLST was not on file. So we interviewed people about their current preferences, then looked in the record to see what was written down. If that facility didn't use POLST, they were missing or had inaccurate information about preferences over 60% of the time. That was significantly greater than the 40% discrepancy we saw between POLST orders and current preferences. So too high in my estimation, but definitely better when POLST is in place. We also looked at what variables were associated with concordance between POLST and current orders. And interestingly, one of the things we found was that this is a little bit of a complicated model, but we found that when we adjusted for all these variables that were significant, the thing that was most important was when they had a preference for comfort, they were least likely to have concordance. So, if somebody has made that decision or the surrogate has made that decision to focus on comfort care as the plan of care, you're far less likely to see discordance between their current preferences in that order than if they had opted for more aggressive interventions and their form reflected more aggressive interventions. Another thing that was really surprising, when we had our interventionist, our research assistants interview these nursing home residents and surrogates, and we would find discrepancies between what was recorded and what they told us in the interview. And so we asked them if they wanted their forms updated, and over a third of them said, nah, no thanks. So we would say, yeah, but your form says you want to be resuscitated and you just said you don't. And they were like, oh, that's fine. Or, I'm sure my doctor knew what she was doing when she wrote that. So we'll just leave it that way. It was very interesting to us. There, I think, is a part of what I think that reflects is this may not be that important of an issue to some people, even though they generously agreed to participate in our study. It may not be that meaningful to them. Or there may be some sort of learned helplessness or avoidance of the issue. So there are lots of potential explanations for that. I also have a study with a colleague, Kathleen Unruh. I think you saw a picture of her earlier. And then our team is pictured here doing what's called a pragmatic implementation of advanced care planning intervention. We have been implementing that in about 131 nursing homes around the country. And what makes it pragmatic is that instead of our research staff doing the intervention, we've actually created a training that the nursing homes provide to their staff, and the staff actually are the ones who do the intervention with residents. And we've just finished the intervention phase of that 12-month study and are now in the process of getting ready to analyze our outcomes. But again, one of the things that we're really interested in is what is available in the record, like what, and largely there's not much available. So our goal was to create a standard of care and training that would support nursing facility staff in engaging in these conversations with residents and family members of people with dementia. And we have published on that. It just gives you a sense of, again, I started out talking about research policy and practice, and you can see my practice isn't me, having clinical interactions. It's really supporting practitioners in their work. And this is a good example. The training program that we created is evidence-based and provides foundational information, but we're using that to study and learn and hopefully advance both practice and policy in the course of doing our research. I'm really mindful of the time, so I'm just want to make sure I give us time to have discussion. I also, I have worked, as I said, extensively, and they probably have now seen this pretty clearly with interdisciplinary collaborators, and I'm also involved in a couple of studies that are led by my colleagues. One of them is a study called In Peace, or the Indiana Palliative Excellence in Alzheimer's Care Efforts. And this is a multi-component palliative care intervention for persons with moderate to severe dementia who live in the community. So I've been talking a lot about my work in the nursing home, and Dr. Greg Sachs, who's pictured in the upper left, is really interested in these individuals who remain in the community living and cared for by their family members most often. So we have multi-component intervention that includes, unsurprisingly, since I'm part of it, advanced care planning. And we just finished a 24-month intervention with 201 older adults and are just on the cusp of doing our analysis. I also am involved in a study of pulse facilitation and complex care management. That's Dr. Lexi Torkey pictured there. And we're working on engaging in advanced care planning conversations with seriously ill older adults who have complex conditions, and evaluating how that impacts their care a year later. And then finally, because I had this experience, with my current grant doing a pragmatic trial, which is really testing interventions in the real world, I became involved in this study with Dr. Yvonne Liu, looking at a very different kind of intervention, a meaningful engagement intervention for seniors with subjective cognitive decline who live at home. I will say another thing, because of this work that I've been doing, I've been pulled into some national conversations about advanced care planning. There's been somewhat of a debate that I have been a participant in, that's been a really interesting experience. We had a leader in the field, Dr. Sean Morrison, who is the floating head in the middle of that foursome there, who really, he has expressed the belief that advanced care planning is a waste of time, and wrote a pretty deliberately provocative editorial. And so there's been this ongoing back and forth. I think we're honestly now at a point where everyone's in agreement, where we're more aligned and on the same page than that initial editorial might have suggested. But it's been a really interesting experience that continues to really sort of push our thinking about advanced care planning, what's effective, how do we measure it, and what's the best way to provide this support to patients and families. That includes developing new models for thinking about advanced care planning. This is a model I recently created with a colleague, Rebecca Sidori, and trying to think about, the role of care planning across the lifespan, that some of it is done in advance, some of it's really preparing you for the future, and some is really, some of the decisions you face are really more in the moment. But those advanced care planning conversations help prepare you for those in the moment decisions. All right, I think I have successfully left 15 minutes for decision making. Listen to me. That's all I have in my head for conversation. We don't have to make any decisions today, happily. But I appreciate the opportunity. And thank you so much for the invitation. I know Liza put my name forward. Thank you, Liza. And I look forward to talking with you. I will say, and hearing any questions, I'm happy to answer any. Again, this is a pretty non-traditional path. I think years ago, when I was a graduate student, I did a seminar in which we talked about academic pathways. And we had a book that really laid out the experiences of multiple psychologists who had done very different things with their careers. And that was really impactful for me. That really stuck with me, because what it left me with was understanding that really there were many different ways that I could go in career-wise. And it was, I'm in a very different place than I ever expected. And I'm quite happy with it. But it's not anything I would have envisioned when I was in training. I think the only other thing I'll say is I did do clinical practice for many years. I didn't mention that, but I know, for those in the master's program and thinking about a PhD program, that's likely high on your list of your motivation. And I really enjoyed clinical practice, but, one of the things that I found was that the research I was doing, I felt like I could make a bigger difference than I could with the clinical work, and that it, really kind of fit my interests better. And so I slowly over time tapered my clinical practice and shifted to research, even though that's not quite the Boulder model. They really want you to do both clinical practice and research simultaneously, which is entirely possible, but not the path I picked. So, all right, I'm gonna stop sharing, and then I am open to any questions, comments, and please don't feel like it has to be specific to the slides, or anything I presented.
There looks like there's a question in the chat. What would you say was your biggest research question?
Yeah, that's a great question, because frankly, it keeps changing. So you saw the grants that I have really reflect some of the things that were burning issues for me and burning challenges. Right now, what I'm really struggling with and focused on as a significant motivating research question is to try to better understand the complexity of implementation around advanced care planning. And this is taking me in yet another direction around implementation science. One of the things that came out of that dialogue nationally was that the editorial Sean Morrison wrote included this kind of attempt to be glib, too simple, it's too easy a solution. And that's, why it doesn't work. And I was like, actually, I think it's really complicated. After having done a couple of grants at, Optimistic Project, where we're doing sort of this hybrid between research and implementation, I realized that it's actually incredibly complicated. And I think one of the challenges we have as a field is that people underestimate the complexity. And so you have folks, saying, well, we train one, social worker in our clinic to do this, and now we're doing it. And it's like, well, that's great, but it's not enough. It's not sustainable. And we need to do a better job understanding what factors and considerations need to be taken into account when you're doing implementation, and providing more of a roadmap. And I'm back to my maps, for clinicians to be able to implement advanced care planning successfully. It is phenomenally complicated. You have to think about there are different medical conditions. People are at different stages in those diseases. They're getting care in different settings. And all of those things need to be taken into account. What's happening in the broader community? Is there training for clinicians? Are the systems set up to support them? Frankly, it just starts to become a little bit mind-blowing when you think about all the places it can go wrong. So that I would say is now my, is it right to say my Moby Dick? It's like we're trying to take this down, because it's really huge and critically important. And I think not just for advanced care planning, but for the field generally, I think we often underestimate implementation challenges, and that's I think for the broader field of research and science is something we're really struggling with. There are a lot of really tightly controlled trials, right, where you have control over every aspect of the intervention and the system, and you demonstrate an effect, great. But when you go to try and translate it into the real world, it fails because you haven't taken into consideration all these other kinds of critical environmental contextual features and factors. And there was another question. So you spoke a little bit how you initially did not imagine entering this field. Do you have any recommendations for those of us interested in pursuing work in or preparing for the field of implementation and translational science? Were there opportunities or resources you wish you knew about sooner, or you think you could have prepared you better? Great question. So I sort of stumbled into some of this, and you don't have to. I don't necessarily recommend that as the ideal path. But you know, there are a lot of resources where you can learn about, and particularly there are so many groups and organizations that have free webinars that you can sign up for. So you know, if you were interested in pragmatic research in older adults, there's a $54 million National Institute on Aging collaboratory that has regular webinars that are available free for the public to learn about different aspects of pragmatic research. There are tons of resources online and conceptual models that are around implementation workshops that you can attend. And then at a more more kind of applied level, I encourage you to look for opportunities to, volunteer with investigators, reach out to faculty that are doing work on your campus. You know, that's how I got involved in a couple things. I took a chance. I reached out and expressed an interest and got roped in on a couple different things that really were great in terms of building relationships and my knowledge and experience. So I encourage you to look broadly. There also are opportunities through the American Psychological Association. Again, there's just a plethora of training opportunities. The other thing I did when I was I know many of you are planning to move on to a doctorate, and I encourage you to think about doing a postdoc. Typically those have a blend of clinical with some research expectation. And of course, you'll need hours to get licensed. So, that's, you want the clinical piece, but I encourage you, if you have an opportunity to get involved in research, to take advantage of it, to ask proactively about it. Hopefully that's helpful. And then also conferences, professional conferences. I strongly recommend attending those as a student. I think that's a really important part of your professional development. Okay, this was a really interesting presentation. I am wondering where you envision your future work going. I'm also interested in the role of ethics when it comes to advanced care planning and post. You might have already discussed or addressed some of this. Thank you for asking that, Danielle. I did not mention that a chunk of my work is really around ethics. I did complete some additional postgraduate training in clinical ethics at the University of Washington. I think one of the thing that's interesting doing palliative and end-of-life care and geriatrics is the number of people who also have an ethics background, because so many of the issues in working with older adults, working in palliative care, have significant ethical ramifications and implications. So absolutely, ethics is really the foundation of advanced care planning and the post model. The idea behind advanced care planning is really around preserving autonomy in the face of incapacity. So how do you ensure that a person is able to continue to have their autonomous preferences known and honored when they're unable to speak for themselves? So there's all the issues around documenting those preferences so that they're available, working with surrogates surrogate decision makers to help them understand their responsibilities, supporting those conversations between surrogates are really around how do you help that person's autonomy be supported in that context. And then, of course, there's lots of hairy, complex issues around withholding and withdrawing interventions, around, decisional capacity, lots. How do you decide when that person is no longer able to make decisions? There are tons of ethical ramifications related to advanced care planning, post-palliative care. Absolutely. Great question. Other questions?
Could I ask a final question?
Yeah.
All right. So if we zoom out and think about what we can do as either educators or people working in research or people in clinical practice, how can we be more inclusive of older adults and their caregivers?
Oh, interesting. That's a great question, Liza. I do think, I will say, I don't know kind of like what kinds of clinical opportunities you'll have, when it comes to your training. I was interested in geriatrics as a graduate student, and I got assigned all of our older patients in our clinic, which was through our a graduate student clinic that was run through our department. And so that meant I got people who were like my age now. Those were our older patients that we were receiving, not exactly geriatrics, but certainly some of that is about how is your clinical site making its services known? Who are they targeting? Additionally, I think it's being mindful of some of the complexities around capacity, understanding decisional capacity, and when people can actually make decisions for themselves. What are some of the warning signs? I think that's really, I don't know kind of how your program is constructed. I encourage you to pursue education about that so you're prepared and ready for that. I think one of the things that led me down my path is I was completely unprepared to talk to patients who were near the end of life as a psychologist, and it felt I got absolutely none of that in my graduate program, and I'm not faulting my program. It was not, we were an adult clinical psych program, and they did not do geriatrics. And I did not learn anything about serious illness, chronic illness. And I wish I had pursued more coursework in that area and been a little bit more intent on that. So for you as students, I encourage that. As educators, I encourage you to think about incorporating that sort of lifespan perspective into the work that you do and what you teach your students. And from a clinical perspective, to make sure that your services are being widely advertised. I think I just hit really broadly with a very wide brush. The paint's probably a little thin in sections, but hopefully that was a great question, Liza, but it was a big one. I just encourage you to be lifelong learners. I think, that is going to be such an essential part of your development as clinicians, educators, and if you do research as researchers, it's going to be an essential part of you continuing to expand. And I really would love if all of you thought of including work with older populations as part of that path forward. And that may require you to kind of go out of your way to find those opportunities, but I strongly encourage you to do that. We continue to have huge needs in this area. And if you're not taking care of even if you're working with younger adults, you may be taking care of someone who's caregiving for an older adult, to have some understanding of that responsibility and the expectations and the pressures that puts on caregivers. I think is going to be really essential for you to be competent clinicians.
Thank you so much, Dr. Hickman, for this really interesting talk and for your time. I think I speak for all of us when I say that we're so glad that you were able to join us this afternoon.
Thank you so much for the invitation. I really appreciate it. And if anyone has something they think of later, or they want to ask me about something, feel free to reach out. My email is very simple. It's hickman@iu.edu. You are welcome to reach out. Find me online easily too.
Great. Thank you so much.
Thank you, everyone.